Everyone, good morning. Nice to see you all here. I appreciate your time. My name is Amanda Terry, and I'm the Senior Director of Research and Evaluation at Unite Us. For those of you who don't know us, we are a closed-loop referral technology company. And today I'm going to be sharing our social care best practices, learnings from a technology-enabled closed-loop referral network. And I need the, So my co-authors, co-presenters are joining me in the room today, my Unite Us colleagues in our research evaluation team. We are all employed full-time by Unite Us, and we have no further financial disclosures. So for those of you who are new to closed-loop referral networks, I wanted to just pause and set the stage first on what a typical workflow in our system might look like, and then dive in a little bit into the evaluation work that I'll be sharing today. So moving from left to right on the screen, we see Tom shows up at Sue's organization. Sue screens Tom. She performs an SDOH screener, identifies that Tom has multiple co-occurring health-related social needs. Sue then uses the technology to gain digital consent and electronically refer Tom to multiple community resources. Those community resources, in turn, reach out directly to Tom. They provide care for him. And as Tom is receiving that care, Sue can log into the platform. She can look at Tom's cases. She can see updates as they occur. And then when the cases are closed, she will be able to see that the outcome and the resolution of that need. So that's designed to be a very simple and intuitive workflow, but as you can imagine, there's a lot of work going on underneath that to make all of this work effectively, and ideally to make sure that Tom, whatever door he enters into, actually receives the care that he needs at the end. And so one of those processes is at the front end, organizational buy-in and change management. So every organization, health system, health payer, government agency, nonprofit who adopts a system like ours does have to implement change management within their organization to make this work effectively. And then secondly, we have community level buy-in and change management. And so that has to be happening simultaneously. We have to collaborate as a community around what this looks like together, again, to make this workflow actually happen. And so these were the two processes that we decided to dig into a little bit with a process evaluation. And just quickly, process evaluation that we conducted really aligns around two evaluation questions. One being, what factors support or hinder adoption? And the second being, what factors influence community partner participation in closed-loop referral networks? We conducted these process evaluations between October 2021 and May of 2023. And we actually conducted 22 focus groups, 103 key informant interviews across 44 states, and we had a representative sample of health systems, health payers, and community-based organizations participating in our networks. We actually conducted all of this via Zoom. We did record and transcribe these, and then we used in vivo qualitative data analysis software for our analyses. And so I could talk for a long time about what we found. That's a lot of qualitative data. So afterwards, please feel free to come find me and I can chat with you. But for today, I wanted to just synthesize it down to 3 key facilitators for successful adoption, and then 3 key barriers to successful adoption. So the first facilitator we identified is having a robust network. As you can imagine, those folks who are actually using the software to refer individuals for care want to know that there are network partners on board who are going to be responsive in a timely manner, and that ideally there are enough of the right service providers to address whatever the client or patient's needs might be. Secondly, clear objectives. So with this, we find that organizations who are clear-eyed about who at their organization is the right fit to do this work tend to find the most success. And additionally, digging down just a little bit deeper, not only is it the right fit role, but it's also identifying some realistic expectations around, for example, what is the target patient volume that you want to see per month in terms of referrals that's based on caseload and patient volume, and ideally an understanding of the proportion of those patients who both may have a social need, but then also who are likely to consent to be referred for services. And then the last one is having one system of record. So this came up again and again, is that oftentimes, having this documentation in one place really supports patients and clients not falling through the cracks. And that's the thing that we're really trying to avoid. One end user highlighted this when they stated, it's much more organized. I know where everything is. Before we started using it, our stuff was all over the place. We either had notes written down in this random website that only half of us used, or we would write them down on someone's folder on the inside. So it's nice to have one place where everything lives in harmony. So I don't know if that sounds familiar to some of you, but I found that to be a really illustrative quote. Now, in terms of barriers to adoption of closed-loop technology, again, we found community participation to be the key barrier to adoption, meaning that if there's a perceived lack of CBO responsiveness, if an individual feels like the referrals they send are going to go unmet, then they simply will not use the system, full stop. Second is, again, change management. So organizations that simply purchase a system and make it available to their entire workforce often don't see the value in the system that organizations do who have put it together a strategic plan, have a vision around this, how this should be implemented in their system. And then finally, systemic and regulatory barriers also came up. So in terms of some of the regulatory barriers, what we find is that often, I'm sure you all are familiar with this, multiple data systems really impede adoption of new data systems. So wherever those redundancies exist, that is a significant barrier to adoption, and things that we try to mitigate by, for example, interoperability. And then second, there are product barriers, key features within our system. For example, we don't require social security number or legal status to be documented in order to serve folks, but we also understand sometimes those are eligibility criteria specific to programs. And so when those data are missing, those programs have a hard time being able to effectively use the system. And just to the point around multiple data systems, this was another illustrative quote from an end user. But adopting new systems can be very challenging, and I think many of us, myself most definitely, are managing so many different platforms and so many different processes that any new one can be quite stressful at times. So I wanted to just, again, I could talk for a very long time about just the qualitative data, but we did want to build a little bit on the process results and actually look at workforce impact, where some closed-loop referral networks are actually implemented and working effectively. We want to know what is the actual impact on the workforce in those examples. And so the first question we asked related to this was, does closed-loop referral technology increase efficiency in care coordination compared with traditional methods? And so we did a longitudinal survey between February 2023 and February 2024. End users were prompted at their very first login into the system to go ahead and complete that baseline survey. And then again, after they had completed at least 6 system logins, they were prompted to do the follow-up survey. We internally developed this tool. Essentially, it was a survey tool to just capture reported time spent on each care coordination activity, again, pre and post. So using traditional care coordination methods versus using a closed-loop system. So you can see these are our results. We actually had identified about 13-minute time savings on average per case. We had 101 individuals who ended up completing that pre-post survey, and so we found a statistically significant improvement in time saved. And then how we got to this end number here is we actually applied that 13-minute time saving across every case in our network, across all of our networks for the year of 2024. And we have an estimated 145,352 hours in efficiency gains. And just to dig a little bit into the reason why we might be seeing some of these types of efficiency gains, I wanted to bring up this quote from one of our end users. I appreciate that the technology takes the follow-up off of our hands as we're so busy with other patient needs and don't always have time to make multiple phone calls to connect patients with resources. So, perhaps digging in a little bit to the why in terms of that, mitigating the need to have to do a lot of follow-up phone calls, emails, that sort of thing. And then some of our partners have been asking the question around, do any of these types of systems actually reduce burnout in our workforce? Burnout, we know, is a really significant issue within the care workforce. And so another question we asked was, does closed-loop referral technology impact feelings of burnout among end users? To answer this question, we did a cross-sectional survey. This was in May of 2024. We used the Copenhagen Burnout Inventory, which is a standard burnout tool. And we had 1,125 total sample size complete this survey, and they were stratified by these types of end users. So we have baseline, which means that they have an active software license, but they've never actually sent or received a referral, so they're not using the closed-loop referral technology yet. We also have the low referral group, which are sending or receiving between 1 and 3 referrals per month on average. We have the high referral group, which is more than 10 referrals on average per month. And then the resource directory folks, again, are not using the closed-loop referral technology, but they are sharing resources electronically with their patients or their clients. And so what we found with this survey was some statistically significant reductions in work-related burnout, specifically among those individuals who are using that closed-loop referral technology. So the folks who were both on that low and the high referral sender groups, that's where we saw this reduction in work-related burnout. And then for the high referral groups, they were actually 2 times more likely to report that it was the technology specifically that was reducing their feelings of burnout. So again, I'm a qualitative researcher. I like to know why. Why are we seeing this? So this is another illustrative quote to try to help us get to that question. So this CHW stated, being able to track the outcome of the referrals I send and follow up with partner organizations has been beneficial in combating feelings of burnout. Being able to know and have connections to our partner organizations helps to foster a sense of community and belonging for me. So, am I good with time? Perfect. Okay. So I'll just end quickly with 4 key takeaways in terms of closed-loop best practices. So we have sustained community engagement. So building on existing networks and initiatives that already exist. So our ideal is to take those relationships that exist and simply make them more efficient by layering the technology on top of that existing infrastructure. Second is embedding the why, so articulating the why early and often with the workforce who are expected to implement these systems. Third, engage champions and organizational buy-in. So the way that we generate buy-in at every organizational level is by empowering, again, each of the different divisions in the workforce who are going to be implementing it and making sure that we have go-to trusted peers within each department. And then lastly, data-informed approaches and role fit. We talked a little bit about this already, but making sure that it's the right folks at the organization, and then aligning early on expectations around what this implementation should look like and what the target expectations are. I'm going to skip that because I know we're at time. Thank you so much. Happy to answer your questions.